I think that is critical in many ways. I mean, that is life-saving for everybody to completely to be aware entirely of what their roles are in a given scenario. And what's great is being in a teaching institution like we are, that for the residents and attendings and physicians, they actually simulate it. There's a simulation lab that the residents and the physicians will go to, because it's hard to speak to every scenario that's going to come in. But really, in a simulation lab, they have these high-end mannequins that are controlled, that their heartbeat and everything is put into different scenarios, and literally what you're simulating is what is your role in this scenario, in this position. Somebody will be a mock nurse, somebody will be a mock physician, somebody will be somebody else, and really when you have moments to save somebody, you really in the back of your mind can't be so worried about what somebody else's role is. You really have to be very fixated on your role. When I'm the attending physician in a trauma patient, I have the head of the bed. I'm the ED physician. I have the head of the bed. I have to manage that patient's airway. I have to get a breathing tube in, and the trauma surgeon needs to be down below the head and worried about, is there a gunshot wound to the chest and to the abdomen. If he's worried about me putting the airway in and I'm worried about him controlling that, then we potentially may have lost that patient. So it is absolutely critical that we do that, and I really like that the way modern emergency medicine academic practices are going is really incorporating simulation a lot, to really be able to kind of go through these scenarios, test it out, and then you videotape it and you're able to see yourself in it. And really, it's a great educational tool. Myself, I'm 4 years out of residency, so I'm still kind of closer to my residency years. I feel strongly that the best teaching program is the best clinical program, right? If I'm a resident, I want to, when I step into the real world, so to say, outside of residency, I want to make sure I've learned in a best practice environment, right? I want to make sure that not only can I just go work somewhere, but I can come and contribute. I can contribute to the process improvement of a department. I can contribute to the betterment of that community's emergency department. So I think the two go absolutely hand in hand in regards to best clinical care, best efficient and the most efficient care, which I think completely augments and supports great teaching as well. That's the only way you learn. You want your physicians, providers, staff to the best you can, working up to the top of their certification, right? I mean, I think that's what you would want to optimize. That, and also that also leads to kind of a competent and satisfied staff member, right? That if I'm a nurse who's doing work of a nursing assistant, then I may not be I'm not going to enjoy that. I'm not going to live up to that. If I'm a nurse practitioner who's doing work of a nurse and all the way around. So, but this is actually very well proven as to what an appropriate scenario for a nurse practitioner and physician assistant is. At the same time, you don't want anybody working above their scope either, right? And I think that's where the challenge comes, and that's why when we go back to the communication piece, it's so key, right? You have a quick triage. A nurse spends moments with the patient to determine whether they're critical or not. Then it goes to a nurse practitioner, PA, who then determines whether can a nurse practitioner continue this, or can a physician? Does this require physician level of care? So really, you allow the nurse practitioner to bifurcate the patient. Is this above our comfort level or our scope or not? And then also, even beyond that, ultimately, every patient in the emergency department is the physician's responsibility. Every patient that comes through, it is the physician's responsibility, right? So they are, so that is on a micro level and a macro level. On a micro level, from shift to shift, from patient to patient. And then on a large scale, hey, educate everybody. Let's make sure they're involved in the processes. Let's make sure we're educating them, we're teaching them. My first 2 months here in my position, I was really working on putting in protocols and educating and providing teaching material for our nurse practitioners, because we recognize that's so key. So also the way you structure the emergency department in regards to zones is to allow acuity appropriate patients to be seen by the appropriate personnel, right? If it's we have a nationally recognized triage system, 1, 2, 3, 4, 5, and we kind of bifurcate the 3s, right? The middle patients, that the low level of those patients and the 4s and 5s, lower acuity patients, can be seen by appropriately by a nurse practitioner and PA. But even if it's the lowest acuity of patient, If a nurse practitioner ever has an issue, then the physician is there to back the patient up, back the provider up.